Levi, who I will be admitting today, is a 2-year-old Schnauzer, and he is a neutered male. Any medical records that he has, any past medical history, is that he actually has a cyst. So those would be, he has 2 big cysts. So those cysts are the masses that we will be removing today. He also has periodontal disease stage 1. So while we are removing those masses, we're going to go ahead and clean his teeth while he's under anesthesia. The process I do in the morning is the patient will come in between 8 and 9. I will walk them into an exam room. The first thing we will do is go over a few questions that I have. So our specific hospital, we are all electronic. So I actually pull up a set of questions, which I will show you now. So these are our surgery admit questions. So as you can see, I am currently in the medical condition of Levi, and a procedure to be performed would be our dental cleaning. We have several questions, including who is present at the visit, who to contact with results, PET scan for the microchip, any coughing or sneezing, food and water removed, is dependent on any medications or supplements, any deciduous teeth coming out today, any allergies, preoperative blood work done, and ECG complete, which we require before any of our patients go under anesthesia here. Description of pet's possessions, be very specific so nothing gets lost. ID collar identified by the client, and HOC is Heart of Chelsea, so that is our hospital name, and has been fastened. So making sure that the pet has a collar on, as well as that owner initialed it, as well as a employee. So on February 22nd, Levi actually came in to do his pre-surgical work. So these are the line items right here. So he came in, he did his ECG, as well as his preoperative blood, which we got the results right here. So our company Antech sent that back to us. And if we click on it and open it up, we'll be able to see the results. So everything looks fairly normal. So he got okayed for surgery today, as well as his CBC. So that was his vet screen, and this is his CBC. His platelets are a little low, but our veterinarian did say that was okay, and he will still undergo his procedure today. So after going over all of the questions in my medical record, I will go over the estimate with the owner. So this is our estimate today for Levi. We have our anesthesia induction, our anti-nausea injection, antibiotic injection, our dental package, and our dental x-rays. We actually have 2 mass removals, so one up here, one down here. Our IV catheter placement, our fluids, our licensed tech monitoring, and etc. So once I have gone over our estimate with our client, they will fill out this specific information. So the first is our client's name, pet's name, today's date and time. The date and time of Levi's last meal, most recent meal, which should be last night before midnight, usually around 8 p.m. The primary phone number. So we asked about the primary phone number. So this would be the phone number we call when Levi wakes up. We also asked if they would like a microchip while Levi is under anesthesia. It's easier to place a microchip. And then we have our owner sign here and date, and then we have our witness sign here and date. So the witness would be me, which is an employee. Okay, to go into more specific detail about the procedures to be performed today. So the first one would be the dental cleaning. So that would be scaling and polishing. But before we actually do that, I apologize, we will take dental x-rays of the full mouth. The main reason why we do that is to check the root underneath the gums. This is something that we cannot see with the naked eye, so it's a very good idea to do that. This will determine whether we need to extract teeth or not. Since Levi is 2 years old, he may or may not need teeth extracted. Dental x-rays will let us know that. After that dental x-rays, then we will scale and polish the teeth. After his dental cleaning, then we will move him into the operating room, and then we will remove those 2 masses. So after going over all of my medical condition questions, as well as going over our estimate, I will bring the pet downstairs. I will bring Levi downstairs. I do have 3 items that I will have with him. So the first one will be a little possession tag. So this tag will go on any items that Levi comes with, whether it be a carrier, or a sweater, or a leash, or harness, anything like that. So we make sure that he goes home with all of his items. The second will be his collar. So this collar has his name on it, his first and last name. This will go around his neck. This will be on during the entire procedure and until we discharge him later tonight. And then we also have his cage card. So this cage card has his name, the date, the procedure he is getting, as well as any items will be listed under here that he came with. Typically, once I bring Levi downstairs, that is where I get his weight and temperature, and I will do a full exam, get his respiratory rate and his heart rate as well, and wait for the doctor to come down. Once the doctor will fully examine him, then we will determine the drug calculations. So this is not Levi's histopathology requisition, because we have not actually entered that in yet, because it has not been done yet. But this is another patient we have here. So this is Sadie. So this is all of her information as well as our doctor's information. Our information up here, which is Chelsea. And then down here we have our histopathology description. So we have one tissue, our notes, right lateral stifle, 6 millimeters punch biopsy, as well as more information down here. It's kind of just explained a little more thoroughly. Yeah, any other comments or patient history that the doctor did not feel the need to fill out. So we will be sending this with her histopathology out to the lab today, and we will hopefully get it back in, typically it takes 3 to 5 business days. So this is our anesthesia sheet today for Levi. As you can see here, it says his patient name, the date, the signalment, the doctor, his weight, the procedure that's going to be performed. So since we have not started his procedure yet, we have not filled any of this out. We have start time for anesthesia and the procedure, as well as stop time. We have our large list of our preoperative checklist, preparation, anesthesia machine check, during procedure checklist, our risk assessment, which is done by the doctor. We have all of our drugs and fluids and agents used here. So our preoperative drugs, our antiemetics, our antibiotics, our NSAIDs, induction drugs, fluids maintenance, etc. Then on the back, so this is the information that we fill out when he's getting his dental cleaning. So as you can see, we have all of our teeth here. Any additional notes, our dental keys, our key here for vital signs and gases, and our vital signs and gases up here, and our monitor signature at the end. Okay, so today I will be going over discharge instructions. So the patient that I will be going over discharge instructions is for Cashew. So Cashew is a 6-month-old neutered male. He was just neutered a few days ago, so I will be going over his discharge instructions just like I did a few days ago. So with the neuter, his procedure may have been short, but it's definitely possible that he will be pretty sleepy tonight just because of the side effects of the anesthesia. With his specific incision, just make sure that you definitely keep a close eye on it. He does have sutures in there that we will need to remove in 1 week from today. Typically 7 to 10 days based on the owner's preference. During that 7-day time, we recommend just rest and relaxation. We would definitely recommend having a cone on him at all times so he doesn't lick and infect his suture area. Just to keep an eye out for anything that's unusual around the suture area would be redness, swelling, discharge, any yellow-green discharge, normal crusting. Crusting would be typically normal. If it is because it is scabbing up, that's a good sign of healing, as long as those other symptoms aren't there as well. So these are our discharge instructions. So we have the patient name, the doctor's note. So it says Cashew was neutered today. All went well with his procedure. Cashew may be a little groggy tonight, might vocalize some. This is a result of the anesthesia. For feeding, it's totally normal to feed him his regular diet. You might want to feed him a few hours after he goes home today. Restricted activity is advised, so those sutures stay in. The medication he will be going home with is for pain and swelling. So this is meloxicam. So this is an anti-inflammatory. The instruction for this is 1 syringe by mouth, preferably giving with food or water every day for the next 3 days. Since we gave him his first dose today, the patient will start it The owner will start tomorrow morning. And then at the bottom here, it does give a few side effects of the anesthesia. So it is normal for cashew not to defecate for 24 hours. Some patients may experience a soft cough after anesthesia. That is due to that. That is due to intubation. If this cough doesn't resolve in the next few days or he has difficulty breathing, please let us know. Okay, so today with Levi, I will be going over how to restrain for blood draws. So he's a little nervous, as you can see. So I'm going to go very slow with him. So the first one I'll be doing is if we were going to be drawing blood from his jugular. So I'll be holding his two front legs and holding his neck up like this and stretching his legs out like that. Good boy, not so bad. The second one would be drawing blood from his leg, from his cephalic vein. So that would be me holding his head like this, close to my chest, so that he's not biting the person drawing blood, holding behind his elbow, and then twisting and putting pressure on the vein so it gets nice and plump for us like this, and holding his paw out just like that. Good boy. Now the last one would be for the saphenous. So for his saphenous vein, I would hold his hind leg out like this while still holding his neck away from the technician drawing blood, and I would apply pressure right above his knee so that we could draw blood at the saphenous vein right there. So I will demonstrate how to properly move a patient in and out of a cage. So if my patient happened to be aggressive, which this puppy is, I will open my cage. Typically, I do like to turn the patient's rear end towards me, just in case of lunging. I know, it's okay, Bishop, it's okay. Just like this. And then I would come into the cage, scoop my patient up, turn around, just like this. So then I have him in my arms, and it's most important that if he did want to snap at me, that his face is away from me. In case we do definitely have a lot of cases where patients are very cage aggressive, where we do have to be very safe. So that's how to properly take a patient in and out of the cage. So now I'll be placing him back into the cage. So I'm going to face him face to the back of the cage, place him in. Make sure I keep a hand on him as long as I can so he doesn't jump out. Tuck my blankets in. Close our cage. Make sure it's securely locked. And that's how to put a patient back into the cage. Okay, so I'll be showing how to safely apply a muzzle. So going from the back, I will put the muzzle around the head like this and clip it and then tie it pretty securely so that he cannot get out. Just like this. And that's how you apply a muzzle. Okay, so today little Benny got neutered. So I'm gonna place a collar on him, so he will have the collar on for 1 week before we remove the sutures. So I'm gonna place it like this, make sure I don't get his eyes, make sure that his ears are out, and then I'm gonna tie our gauze string. Not too tight, make sure that 2 fingers could still fit underneath. Just like this, and he will have the collar on for 1 week. Good boy. Okay, so we have Chewy here today. So she will be getting spayed today, so I'm going to do a little pre-assessment exam. So the first thing I'm going to do is her TPR, so her temperature, her pulse, and her respiration. I'm going to see her temperature.
Lisa is ready for discharge.
So her temperature was 99.4, which is totally normal, so that's great. And I'm going to take her pulse using my stethoscope, as well as listen to her lungs, and also take a respiratory reading.
Legal is here for Dr. Love.
So her heart rate is actually 140 and her respiration rate is 30.
Yeah.
And the next thing I'm going to do is check her face. So I'm going to do her teeth, her capillary refill time. So first I'll push on the gums for capillary refill time. They're very pink. And the capillary refill time is less than 2 seconds, which is totally normal. Then we take a look at her teeth. So she's 5 months old. So she has all of her baby teeth still in.
Solange, they're coming tomorrow.
So we'll give her a lot more time for those teeth to fill in. Good job. Now I'm going to check her eyes. Alright, so now I'm going to look in her eyes to check to make sure that her pupils are dilating appropriately to light. Go straight. And then her left one looks
Probably
great
in
as
the
well.
machine right now. They're probably autoclaving right now.
And then I'll take a look deep into her ear canals, just make sure she doesn't have any sort of infection or anything.
If it's not a phone call, it's broken routine.
You're checking the ears. First I'll do her right one. Yeah.
Is it actually?
Good. No redness or swelling, nothing like that.
You know how it gets.
Oh, I'm sorry. Good job. Everything looks great in the left ear as well. No redness or swelling.
Return on the other.
Great. Now I'm just going to do a full body exam. So I'm going to start with her lymph nodes and work my way down.
The only other thing I want to know, especially if it doesn't dry, everything completely, even if it did
Not
go through a
swollen.
cycle, is the bed. Help us go. When this isn't drying, that means we have to wash and dry the
Just going to feel her lymph nodes on her behind her knees. Feels good. She's in healthy body condition. She actually is perfect weight. She has a nice little waist and she has a good amount of fat just around her ribs.
Yeah, it's fine.
Ribs.
Every
I'm
5
just going to do a
minutes.
little belly squish, a little abdominal palpation.
Thanks for here for Dr. Wen.
She did urinate before the procedure. I'm sorry, before mom dropped her off, so I'm not feeling a bladder or anything. I'm feeling nothing out of the ordinary. Take a look at her vulva. It's not inverted. Her anus as well. Very clean and trimmed. What do you think? You ready to get spayed? Good. And that was a full exam on a dog for her spay procedure today. So we have assessed the patient and we gave her an ASA grade of 1, which means that she's normal and healthy, and that she's okay to go under anesthesia. So I'll be doing the exam on Captain here. He is our hospital cat. So the first thing I'm going to start with is his eyes. So Captain does actually have a condition called microphthalmia. So this means that his eyeballs are actually extremely small and his eyes are very sunken in. I know, you're okay, good kitten. You're okay, honey. That's good. So I definitely still see a pupil reflex, which is good. His pupils are still responding to the light, which is very important. I do see a lot of discharge coming from his eyes, which is very common here, which we see a lot. We do have to clean his eyes twice a day. He does react to some shadowing, but we do anticipate that he doesn't see too much. Next, I will look at his ears. Let me see. Oh, I know, this is the worst part. But it looks pretty. Oh, it's okay, it's okay, it's okay. It's done. He does not not like his ear exam, but they are very clean. Maybe slight debris in his left ear. Okay, now that his eyes and ears, I've taken a look at both of those. I'm just gonna take his heart rate as well as listen for any arrhythmias or murmurs, and then listen to his lungs, listen for any crackles or any harsh sounding that could actually indicate pleural effusion or upper respiratory infection, pneumonia, something like that. So I'm gonna make sure this is good. So first I'm gonna start with his heart rate under his left arm. So I listen for 6 seconds. I'm gonna multiply it by 10. So I got 16 beats. So I multiply that by 10. So his heart rate is 160. And I'm just gonna listen to his heart a little bit longer. Make sure I don't hear any murmurs or arrhythmias. Do you need something? His heart sounds very good. Now I'm gonna listen to his right chest, make sure there's no crackles. Make sure I listen to all of his lung fields. Oh, this isn't so bad now, huh? Beautiful. Take his respiration rate by just feeling his breaths. I'm gonna hold my hand to his chest. Okay. So I saw 3 breaths in 6 seconds. So I'm gonna multiply that by 10, which is a respiration rate of 30 breaths per minute. I heard no crackles, no wheezing. That's great. He definitely has some muscle wasting. He's an old man, so he has some muscle wasting right here in his hip area. He's very clean and well groomed. Just gonna take a quick look at his teeth. Good. His capillary refill time was less than 2 seconds. He's very pink. His teeth have some staining. I'm gonna be checking his lymph nodes. These definitely feel a bit large to me. So he was recently diagnosed with lymphoma. You're okay. I know you're a good kitten. I know. Just feel your back end. Come on, twist around. Just gonna feel his pulses on back here. They're very strong. All of his lymph nodes do feel a bit swollen to me, which is not surprising due to his condition. His belly feels very soft though, so that's good. He doesn't feel uncomfortable when I palpate his abdomen. You can definitely tell just by the way that he's standing, he might have some arthritic changes. Now we're just going to take his temperature if you want to face it. Okay, yeah. You're okay. This is going to be fast. Perfect. Great. So his temperature is about 99.6. Great. So that is perfect. Just take this out. I know, you're a good cat. Okay. So I would grade him an ASA stage 3. Bless you. So I would grade him a stage 3, especially because of his condition, since that he does have lymphoma, and he definitely has some progression of that disease. So he was not the best candidate for anesthesia. So yeah, but other than that, he's on steroids, so he is his everyday life is very happy. He's a good quality of life. Okay, so now I'm going to be drawing blood on the left front cephalic vein. So the first thing I'm going to do is spray alcohol to visualize the vein more. I have my 23 gauge butterfly here. My 3 cc lower lock syringe. I'm going to screw it onto the bottom of my butterfly. Do a slow pull back so I don't collapse the vein. Perfect. Just need a little bit more, and then we're done. Okay, done. Please hold off. Thank you. Now I'll put it in both our tubes, and we'll be sure we're sending out a full panel early detection 2 to 7 on this dog. Okay, so I'm gonna do a jugular blood draw. So the first thing I'm gonna do is spray alcohol around the vein to visualize the vein better. And my 3 cc syringe. Here's a good dog. Alright, you go make a boy, yeah. Good boy. You're such a good boy. Then, stop things. Now I'm going to put it in our red top for our heartworm test, and we'll go out to the lab. So I'll be drawing blood on the side of his vein here. Just going to spray with alcohol to visualize the vein. He's definitely very calm. Alright. Okay, so I'm going to use a 23 gauge butterfly here. And I have my 3 cc syringe. Now I'm just going to attach my 3 cc lower lock syringe. And pull back slightly.
Good job, Liz.
Now I'm just doing very slow pressure, very soft pressure not to collapse the vein. I'm going to try to get at least 2 cc's. Good job, you're very good. Alright, good, that should be more than enough. Please hold on. Thank you. Great. Now I'll put it in our purple top for a blood smear. Great. Okay, so I'll be drawing blood on this kitty in her left front leg, in the cephalic vein. I'm going to use a 25 gauge butterfly. She's a fairly tiny kitten. And I have my 3 cc syringe. Alright, you'll be okay. He's a good kitten. Mama, ready? Little poke. Oh, you're a good cat.
Girl.
Now I'll attach my 3 cc syringe. And apply slight pressure, not too much pressure because you don't want to collapse the vein. Good girl. to send out, Sam?
Mhm.
Okay, good. Please hold off. Thank you. Good girl. Now I'll put our blood in our purple top as well as our red top to send out to the lab. Morning. Okay, so we're gonna draw a little blood for PCV total solids in house. What I try to do is not get people around me. Little baby kittens. Good boy. Good boy, buddy. You know it's okay for me. Good boy. And that's all we need. Amazing. Good job. Good job. Good job. You're a very good boy. And now we can run a PCV total solids. Okay, I'm gonna draw blood on a medial saphenous on a kitty. So I'm gonna use a 23 gauge butterfly and my 3 cc Loralox syringe. First, I'm just gonna spray to visualize the vein a little better. Spray with some alcohol. Good cat. It's okay. It's okay, kitten. Very good cat.
Not doing much.
Alright, we're just drawing a few cc's for some in-house panels for an ISAT and a PCV today. Oh, I'm sorry.
Buzz.
You're okay, kitten. So I'm just drawing back very slow pressure. I'm also squeezing his foot a little bit just to increase the pressure as well, increase the blood flow. Mine as well. Okay, good. And that's all the blood we need. Thank you. So Lauren's gonna hold off now just to stop the bleeding. So I'm gonna put my blood in my purple top first and then in my green top. Good cat. Good job. Okay, so I will be discussing our minimum database for our pre-surgical patients. So here at our hospital, we do require blood work to be sent out to the lab. So that specific blood work will check total solids, PCV, BUN, ALT, blood sugar, as well as several other values that I will show you. And we also do require a pre-surgical electrocardiogram of the heart, which we do in-house here. And I will show you how we attach that as well. So if any of these problems, so if we do get the blood work back and any of these problems show any elevations or anything like that, or if the patient came in for their pre-surgical exam and we heard some sort of a heart murmur or anything like that, the first thing that we would do is radiographs of the chest to make sure that the heart is not enlarged. If the heart shows any signs of enlargement, we would have to do a pre-surgical ultrasound of the heart. So we do have a cardiologist that comes to our hospital and does all of our echocardiograms. So we would require that before we put that dog under anesthesia, depending on the intensity of the heart murmur or not. Any other abnormalities, we would send out additional testing. So for this patient, this is our patient Duke. He actually just had a dental cleaning on Tuesday. So before we did induce anesthesia, he came in for blood work on the 11th. As you see here, we sent out an early detection panel to see the results of that. So the test that we sent out was a complete blood count as well as a vet screen. So the vet screen will check for all these values, including the ALT, the BUN, and the blood sugar. And then our complete blood count will include all of our white blood cells, red blood cells, our platelets, our neutrophils, our lymphocytes, etc. Everything looks very normal. And we also went ahead and ran a heartworm test because he was due for that, and that was negative. And then the day of the procedure, he came in and we did his ECG. So to show you the results of our ECG, We have attached it here. Here are our results of his ECG. Okay, so I will be discussing our peri-anesthetic protocol for proper pain medication, as well as our protocol for during anesthetic procedures. So we all have our anesthesia record here, so I'm just going to go over a few drugs with you. So the first thing that we typically do, so when the patient first comes in, depending on the history and everything, if the patient is feeling anxious, the first thing that we will do is give a mild sedative called acepromazine. Acepromazine will help relax the patient just to make sure that during placement of the catheter and before he goes under anesthesia, that he's calm and relaxed in his cage and he's not too nervous or anxious or causing any self-harm in the cage. So then our next peri-anesthetic protocol. So first we would place an IV catheter. Next, what we actually would give is an anti-nausea medication. So typically that's our Cerenia. With our Cerenia, we do give an antibiotic injection. So typically for the antibiotic injection, we usually do cefazolin. So our anti-nausea medication, Cerenia, we do give Cerenia to prevent nausea, especially before we give our morphine, because morphine can make our patients very nauseous. This will also help during the recovery period. This will decrease all nausea for our patients. Our antibiotic, our cefazolin. So we give an antibiotic before our procedures because if it is a neuter, there is an open surgery site. So it's always very good to prevent infection by giving an antibiotic beforehand. So next, our next step in our peri-anesthetic protocol, so typically we do give an anti-inflammatory, which is a pain medication. So this anti-inflammatory can range from meloxicam to Rimadyl. So depending on it's mostly our doctor preference as well as our patient, depending on the patient's history, species, size, any history of disease, anything like that. So after our anti-inflammatory, we typically give our morphine. So the morphine can definitely make them nauseous, but it is a very good pain medication as well as an anesthetic. So morphine will make them very nauseous, but the Cerenia that we gave prior will help. So we typically do give the morphine about 10 to 20 minutes before our procedure. Make sure it kicks in before we sedate them. After our morphine, our induction agents are typically our propofol and our midazolam. So we will give midazolam first, just to help relax the patient, and then we will give our propofol intravenously, both of them. Propofol is given in IV boluses, just to make sure that our patient goes into the proper anesthetic state during the appropriate time. So once we have given the propofol and our patient is sedated, they are on isoflurane the whole time during the procedure. Yeah, and then as the patient wakes up, we kind of depends on our protocol after, depends on the pain. If we believe that our patient is experiencing a lot of pain, we can give additional buprenorphine or any other type of opioid medication. That is the doctor's preference. For emergency drugs, just during the procedure, we always do have atropine on hand, definitely in case any blood pressure drops or anything like that. That is typically our peri-anesthetic protocol. Okay, here we have our controlled substance logbook. So we have all of our controlled substances organized by file right here. So the substance that I will be filling today is tramadol. So for our system, we do print 2 labels here. So here we have our patient name, we have our instructions. I wrote our mock drug label because this is not a real label. This is our medication that I will be filling, the tramadol 50 milligrams and the amount. So for our specific way of doing this, we will print a label that is actually time-stamped with our licensed veterinary technician or of our doctor of who is filling this medication. So right here I have the initials of an LVT, ZMH, the date, and the time. So this label will go on our tramadol sheet. This tramadol sheet matches the exact bottle number and lot number that we have for the medication that we are taking out of the bottle. So once I place this drug label on, I will sign, as well as another manager, and I will also write the date on this label. And that is how we control our substances. Okay, so today I will be going over parts of the anesthesia machine. So to start off, I will actually just do it how the anesthesia flows. Well, the first thing I have here is our oxygen flow meter. So the oxygen flow meter allows us to get the amount of oxygen to our patient. So how it works is the oxygen will flow through this line right here. It will flow through the back. And then to turn the oxygen on, I will move this to the left, the indicator. So the oxygen is actually expressed in liters in gas per minute. So right now I have it on 1 liter of gas per minute. Next, we have our oxygen flush valve, which is right here. As you can see, it just filled up my reservoir bag. So the oxygen flush valve is a button, and it will actually rapidly deliver oxygen in large volumes to a patient. Because of this, you actually have to be very, very careful with it, because it does bypass the anesthetic vaporizer, which is right here, and it also bypasses our oxygen flow meter. So it will allow us to rapidly fill up the reservoir bag. Reasons that we would do this is for a critically ill patient, so they would need oxygen immediately. And it's also good to dilute. It's also good to get rid of all the other anesthetic gas that is in the bag, so it will help us flush that out in case we want to increase the dose or in case we want to decrease the dose of gas that our patient is getting. All right, great. So next we have our anesthetic vaporizer. So this vaporizer actually converts our liquid isoflurane into a gas. So once it actually is in the gaseous state, oxygen will flow and act as a carrier and actually pick up particles of the isoflurane and carry it to our patient. It is then, it goes into the breathing circuit and directly to our patient. To turn our vaporizer on, we would have to hold down the button, which is a safety button, and then turn it to any notch you want. It goes from 0 to 5. So that is our isoflurane vaporizer. The next is our inlet and our outlet ports, which we have right here. So both of these are unidirectional valves. So that means that gases will only flow one way through them. So this one is our exhalation valve, and this is our inhalation valve. So I would probably start with our inhalation valve, which is on the right here. So the inhalation valve is actually attached to our inhalation tube, as you can see right here. So with the inhalation tube, so with the valve, it opens when the patient breathes in and actually allows the anesthetic and the carrier gas to flow through the tube into the patient, just like this, in that direction. Our exhalation valve, which is on the left right here, is the attachment point for the expiratory gases. So our patient will actually breathe, which is our blue tube in here. We'll breathe in these gases, and then as our patient takes an exhale, it will go out the outside of the tube, this white tube here, and then all the exhalation gases will be flown into here, and then that will be flown. So the exhalation valve carries not only carbon dioxide, but also anesthetic molecules as well that are flowing back when the patient exhales. So the next thing we have is our pop-up valve, which is right up here. Our pop-up valve is a point of exit for anesthetic gases. So this valve actually prevents the buildup of excess pressure of the volume of gases within the circuit. So it is very important not to close this valve, because it could increase a very large amount of pressure to the patient's lungs, and then the lungs can actually expand way too far. So that is very scary. So we always like to make sure that this valve is open unless it is during manual ventilation. During manual ventilation, we do have a button back here, which we would hold the button, which allows us to give our patient a full deep breath. Now to move downward, we have our carbon dioxide absorber canister, which is right here in the middle. So as you can see, it was changed February 26th. This definitely should be changed after 6 to 8 hours of using. So typically we do change it every 30 days. For the carbon dioxide absorber, expired gases are directed by the expiratory unidirectional valve, which is right here, and then they go into our absorber. In this canister, there's a bunch of granules that actually will absorb all the carbon dioxide molecules. Some of them actually do have a color change to them. So after absorption of about 26 liters, so the last thing I'll be talking about is our manometer here. So the manometer is read in centimeters of water. So our manometer actually helps us measure the amount of pressure that we use during manual ventilation, during manual or partial ventilation. So we do have two different systems of our anesthetic machine, one called a rebreathing system and one called a non-rebreathing system. So what I just went over, so that is considered a rebreathing system. In our whole circulating of events, our patient will be rebreathing some of the exhale gases that they have already inhaled and exhaled. So they will be rebreathing these minus the carbon dioxide, because that actually could be very lethal. In a non-rebreathing system, we would use a non-rebreather bag, like this one. In this one, this port is actually directed onto the outlet port right here. And then this is actually going directly into our anasorb. So this completely bypasses our carbon dioxide absorbent. The main reason for this is the fresh gas is actually routed directly to the patient instead of recirculating into the system. The main difference between these two systems is we would only use a non-rebreather for patients that are under 3 kilograms. Okay, so the last item of our anesthetic machine to go over is our anasorb. So this anasorb is actually connected right here to our exhalation valve. So when the patient exhales, all of our carbon dioxide molecules will go into our carbon dioxide absorber, and then all of our anesthetic gases will go into our anasorb, which is down here, which we leave over here and make sure that it is well ventilated. Here is the closet where our oxygen supply is. So as you can see, we have 2 oxygen tanks here. The one in the back is the one in use. So this oxygen tank is on, so it reads about 1,000 or so, maybe a little bit more. So that's how much oxygen we have left. We do rotate between these two and another one that we do have. It is very important for the technician in the morning to sign off and make sure that the oxygen is on before we anesthetize any patients. And then we do also have our monitoring log here. So our monitoring log does allow us to, allow our technician to write down how much oxygen is left in the tank in the morning with the text initials, and make sure that our oxygen tank is closed overnight. Okay, so I will be talking about the importance of checking for leaks on our anesthesia machine today. So it is very, very important to check for leaks because we do not want any anesthetic gases circulating in our environment. We want to make sure that number one, our patient is getting our anesthetic gases to make sure that they are staying sedated during our procedure and that they're not feeling any pain from waking up. And also, we also do not want to be breathing any anesthetic gases. So, okay, so now I will be occluding our anesthetic tubing. So the first step I took was closing off the pop-up valve. So now I will occlude the anesthetic tubing. So now using our oxygen flush and reading our manometer, I'm only going to put it up to, flush it up to 20, about 20-25%. And then hold it for about 10 seconds and make sure that there's no leaks, and then it's not going down at least 1 centimeter per minute. Doesn't look like there's any leaks, so that's perfect. See, my bag is still filled up. And you perform a leak test. Okay, so I will be talking about our pulse oximeter now. So here is the end of our pulse oximeter, and I will show you in just a few seconds our whole machine. But just to talk about it for a minute, so our pulse oximeter actually estimates the saturation of hemoglobin. So it actually does this from this probe. So this probe actually has a little light on it, and it's sensitive to both the absorption of light by hemoglobin and to the blood pulsations under the skin. So this actually determines oxygen saturation by calculating the differences between the levels of oxygenated and deoxygenated hemoglobin. So this is very interesting. It's very good to have this on board during surgeries. So it's always good to place it in areas such as the tongue. You could also place it on the penis. You could also place it on the end of the tail. So for example, I'm going to place it on my finger. So for our patient, it's always good under anesthesia to have them above 95%. If they're under 95%, that means that oxygen is not flowing appropriately throughout their body. This is our pulse oximeter. So as you can see here, the SpO2 is right here, and our rate is right underneath. So this actually gives us a pulse as well, which is very helpful. With every beep, that's typically a pulse, a heartbeat. And if you follow the wire here, this is where our probe is connected here on the bottom. Our SpO2 is 96. We have our capnograph, which is 34. Her pulse oximeter right here on her tongue. I'm just going to demonstrate how to do an esophageal stethoscope and how to place it. So I'm going to put it directly into the esophagus. This stethoscope actually measures not only rhythm, heart rate, and temperature as well. This is the reading for our stethoscope. As you see, it measures our heart rate as well as our temperature and the electro rhythm of the heart. Okay, so I will be showing how to do gastric intubation. So I have measured right here to the last rib. I've also measured here to the last rib using our red rubber. So I will insert the red rubber up until this point. It is good to know how to gastrically intubate a patient, especially if you have to, in case you have to do a gastric lavage or anything like that, in case there was any toxic ingestion. Okay, so since our patient does have an endotracheal tube, I'm actually not going to use this tape. Typically, you can use it to pry the mouth open just like this, but we're going to have our doctor do that instead for me. So it's good to keep the patient in sternal recumbency. Gastrically intubate. Here we have our ECG reading, the electrocardiogram. So this measures the electroactivity of the heart. So we have around 74 beats per minute here. And then for our ECG readings, we also have all of our probes hooked up. Red one here in her hind legs, as well as both of her front legs. Okay, so next I will be talking about our endotracheal tubes, which I have right here. So the tubes actually range from sizes 3 to size 14, 3 being the smallest, 14 being the biggest. So endotracheal tubes are essential in induction of anesthesia. So once the patient is induced and the anesthesia has been given, a technician will place the endotracheal tube directly into the trachea. For size measurements particularly, you could always base it on the space in between both the nostrils on the dog. It is kind of a rough range, but it's always good to have 3 different sizes just in case once you intubate, if you think there's too much dead space in the area, you might want to use a larger endotracheal tube in case, and if it's too tight, you actually might damage the trachea. So in that case, you want to remove it and then put a smaller size in. So for endotracheal tubes, they allow proficient levels of oxygen as well as anesthetic gases to be delivered to our patient during anesthesia. It also reduces the chances of an obstruction. Okay, now I will be performing an endotracheal tube leak test. So I have our tube completely submerged in clean water. I'm going to inflate the cuff and look for any bubbles. this tube and is okay to use for surgery. Okay, so next, a monitoring technique would be monitoring respiration rate. So respiration rate, without using a typical machinery like capnography, respiration rate can be monitored manually just by looking at the chest, inhale and exhale. And it also can be monitored using the reservoir bag, which I have right here. So the reservoir bag, you can watch as the patient inhales and exhales. So that helps us count breaths while the patient's under anesthesia. Using machinery like a capnograph, so capnograph measures the amount of carbon dioxide exhaling from the patient. So that will measure whether the patient is holding their breath, whether the patient is breathing rapidly or taking very big breaths but short breaths. So capnography is a great tool as well. So this is our oscillometric blood pressure monitor. So this machine will measure our blood pressure. So it measures our systolic, diastolic, and our mean arterial pressure. As you can see right here, these are the 3 different readings that it will give us, as well as this one actually measures our heart rate as well, our beats per minute. So this machine is connected to a cuff. Here is our cuff. So it actually ranges, every size ranges depending on the animal. But specifically the width of the cuff should be about 30 to 50% of the circumference of the paw, of the leg. The cuff definitely should not be too firm or too tight. So how blood pressure specifically works, the cuff, so it actually measures the oscillation in the cuff pressure, which is caused by the pulsations of the artery beneath the cuff. We have our blood pressure reading, 94/43.
Do you want to do the molar?
MAP is 68.
Okay, so why don't you...
So we have a size 1 cuff on our patient here, which is attached to our monitor. So last we do have our thermometer. So our thermometer does come with a thermometer sheath, so that we need a new thermometer with every new patient. You just go ahead and remove it. It's always good to use lubricant when taking a dog's temperature. Dog's temperatures range between 98 and 103.5. Anything above 103.5 is considered a fever. I'm now taking our patient's temperature, which is 98.2, which is beautiful under anesthesia. Okay, so this is my preceptor for our program. Her name is Rachel Lincoln. She has been a licensed veterinary technician for 7 years. So she actually went to Suffolk Community College. That was her veterinary technician program. She's been working at Heart of Chelsea Veterinary Group for 6 years now, and she's taught me all that I've known and all that I will know. So we're very excited. So we're going to be placing a catheter on Tina for her dental cleaning today. First, I'm going to clip the hair on her leg. I'm going to start my first scrub, 1 of 3. I have a 22 gauge Surflash catheter. Now that I got a flash, I'm going to advance my catheter, hold off, and place my hub. Okay. Now I'm going to take my 1/2-inch tape, sticky side up. You're okay, buddy.
No, it's about to come off. I'll just put it back.
Perfect. Now place a 1-inch piece of tape. You're okay, Baba Ganoush. You're okay. For support around the catheter. Perfect. Now I'll put my injection cap on. Perfect. Now I will flush to make sure the catheter is clean. Beautiful. Now I'm going to place another 1-inch tape underneath my injection cap to secure the catheter further. Oh my goodness. Captain, stop eating my stand. Great, and I'm just going to flush one more time. I'm just going to place some vet wrap for extra support. Making sure that the vet wrap is not too tight. Perfect. Now she's all set to get her preoperative medication. Okay, I'll be placing a catheter on the saphenous vein of a little kitten who's going to get spayed today. So the first thing we'll do is shave the area. Now I'm going to start my scrub. So I'm going to do this 3 times.
Just a little bit more.
Okay, now I'm going to hold off. Take my needle hub out. My 1/2-inch tape. This is a very good kitten. Now I'll take my 1-inch tape to stabilize the catheter. Are you hungry? Oh, thank you. Sorry. Great. Now that I have my 1-inch tape on, I'm going to put my injection cap on. Great. And I'm going to flush to make sure the catheter is patent.
Great.
And I'll apply another 1-inch tape underneath. Is this going to block her little foot?
No, it shouldn't.
Thank you. Now anchor the catheter.
So cute.
Perfect. Good job. Okay, so I'm going to be giving morphine IV. So today she came in for quite a bit of back pain. So we're going to give her some morphine and then do some radiographs. So first I sprayed some alcohol just to really part the fur. And the vein more identifiable. Okay, baby. Hello, honey. Measure the toe vein. There we go. Let up. And I'm giving the morphine very slowly because it can make her a little nauseous. Okay. Good. That's how you do an IV injection. So I am going to be preoperatively medicating this little puppy right here for her stay. So right here I have morphine. So I'm going to be giving this injection IM. So I'm actually going to be giving it in the the right epaxial. So first I'm going to put my finger right on the spine and then move my other index finger about 1 inch away and then make sure I feel the muscle here. I'm going to stick our needle in, pull back, just to make sure I'm not in any blood vessels. And I pull back, no blood, and I'm going to inject. Done! Done! Now it's how to do an IM injection. Okay, so we have Chewy here today. So today she's going to get spayed. She's 5 months old. So what I'm first going to do, so I have her non-steroidal anti-inflammatory right here. So this is a Medicam, and I also have her Serenia, which is the antiemetic that we will give preoperatively before her procedure. So the non-steroidal anti-inflammatory I'm going to give sub-Q. So I'm just going to lift her skin, do a little pocket here. It's okay, mommy. A little poke, a little drawback. Good. And good job. Okay. So now that we gave her non-steroidal, now I'm going to give the antiemetic injection, the Serenia. So just to make sure. Okay. So first I'm going to flush her catheter and make sure that it's patent. Good. Feels beautiful. Now I'll give the Serenia pretty slow. You're really, really good. Okay, perfect. And now I'm going to flush one more time just to make sure that she gets all of the medication. Good job. Okay, good. And then we'll move on to our next step. Okay, so before we do anything, we will pre-oxygenate our patient for 5 minutes. For the pre-oxygen stage, we have our anesthetic machine, our oxygen hooked up, and we will hold the mask with our oxygen flowing for 5 minutes before the procedure. Okay, so we are getting ready to perform Chewy's stay procedure. So I have 3 injections here. The first one I have is the midazolam, the propofol, as well as just a flush. So the first one I'm going to give is the midazolam. First I'm going to flush just to make sure the catheter is patent. Beautiful. And then I'll give her the midazolam. Flush one more time. And now I will be administering the propofol. So administering propofol, you have to go very slowly, but not too slow, because you don't want them to stay in the excitatory state for too long, because it can be pretty hard on them. They're very confused, and so it's good to not go too slow but not too fast.
overall, she's definitely improving. You know, she's brighter. She has less nasal discharge.
See?
You know, she ate overnight.
Position
Again,
here.
I think I probably heard this in the message. She wasn't interested in eating this morning. Yeah, the
I think she
you know,
is sedated enough.
you know, coughing.
So I'm just gonna flush
quick
one more
enough,
time.
But, you know, the only thing that concerns me is she's still breathing pretty quickly. You know, and
So now I will be using the laryngoscope for intubation. So I have three sizes here. I have a 5, a 5.5, and a 6. So I'm gonna start off with the 5.
She ate a full, you know, she ate a full meal overnight. We weren't gonna force feed her.
So I'm putting it in the
every few
lidocaine
hours,
for
You know, we
lubrication.
sit with her and we hand feed her to get her to eat. If they're not eating at all, sometimes we'll do kind of syringe feeding. But you know, we try not to do that. We try to just add in medications to help their appetite. Because sometimes when we do tube feeding, it that deters
And I'm
them
gonna
from
tie
wanting
it
to
off.
eat even more. So it's certainly we'll do that if they won't eat anything. But she ate again everything overnight. And we'll hopefully every few hours.
Now I'm gonna tie it around her head for support.
The not eating.
Good. And I'm going to inflate my cuffs.
Not the way she is,
Just to check for leaks, I'm pushing down on it and it's not deflating.
Pretty fast, because they're stressed. But I think
All right, now we'll set her up for preoperative scrubs.
a little bit later than probably related to the pneumonia.
Then I'm gonna lubricate her eyes. Thanks for your. So Rachel will be monitoring her as I prep her. So first I'm going to do a shave. So the area I'm going to shave for her stay is from the xiphoid and outside of the edge of the ribs to the pubis. So it's always good to make it as aesthetically pleasing as possible, but also we want to make sure that we're clipping all the hair around the surgery field as we can. It's also very important to be very gentle with the clippers because it can cause some skin irritation if used too harshly. So I'm just going to check the bladder and make sure that it's empty quick. So the bladder does typically feel like a little bit of a balloon. Her bladder feels pretty flat, so she doesn't have any urine in there. Which I'm not surprised because she did urinate before the procedure. Okay, good. So now that I know that she doesn't have any urine in her bladder, I'm going to start scrubbing. So I have two different scrubs that I'm going to use. The first one is chlorhexidine scrub, and then the second is alcohol. So I'm going to do this 3 times, starting from the incision, from the middle, and outwards. And once the gauze touches hair, it does have to be thrown out. There's my garbage right here. Perfect. I'm going to do alcohol. So this technique is actually called the bullseye technique. So starting from the middle, where the incision was. Tracy. So 9:30 is actually going to be my towel here. We're nice and warm. And try to keep this, there we go, the field as aseptic as possible. Sorry, como. Perfect. Beautiful. I'm gonna hook her up back onto our ASO. Thank you, Rachel.
Oh, the urethra, the one that was blocked. Yeah. Yeah. It ended up having a splenic.
You could do it. So Rachel is attaching our ECG leads.
The craziest thing.
So we have the red one on left hind, the black one left front, white one on her right front.
She got the spleen all on the day surgery, and then the dog came in and was like, and it developed ITP, which is the amputated thrombocytopenia, and we did a CAT review on it, and the dog has babesia, and they said that when you remove the spleen, sometimes they can get like babesia that's kind of like been in
I'm
their
attaching my
system.
whole cup over here.
So like now the dog will.
She's very pink. Her heart rate is normal. And she's breathing great. Great. So we have our SpO2 reader here, as well as our heart rate and our blood pressure monitor.
So it's enough.
Thank you. Actually, if you'd grab it for me, so I don't go back out. Okay, I'm going to perform the last scrub now with my chlorhexidine. And my alcohol. Okay, done. Now she's all ready for her surgery. Hooked up to ECG leads. We're monitoring his heart rate, his electrical activity, as well as blood pressure. His heart rate is looking good. He's very pink. His CRT time is great, and SpO2 is great as well. Okay, so I will be demonstrating how to do cardiopulmonary resuscitation. So God forbid that you realize that your animal, whether being in surgery or if an animal comes in during an emergency state and you realize that the animal is in cardiac arrest, cardiopulmonary arrest, which means that the animal is not breathing and does not have a pulse. So even if you're an owner at home, the main things to look for are what we call the ABCs: airway, breathing, and circulation. So airway, checking if there's anything lodged in the mouth that you could see that you could pull out. So opening your animal's mouth, pulling out the tongue, and seeing if there's anything obstructing the airway. B is breathing. Is your animal breathing? C is circulation, so feeling a pulse. If this is an emergency state, if you, after opening the mouth and you do realize that your pet is blue, if the gums are very blue and pale, that means that they are not breathing and that their heart is not beating and they're not getting sufficient oxygen to their whole body. In this case, it is a good idea to start cardiopulmonary resuscitation. So to start with cardiopulmonary resuscitation, we actually do a series of 2 minutes each. So of these 2 minutes, it would be compressions and then breaths, compressions and then breaths. So first what we would do, so since I have a small animal here, I'm actually just going to do one-hand compressions. So I'm going to take my left hand and just secure the back and actually make sure that my arms are fairly straight. have my hand here and do 30 compressions to the heart. So for smaller animals, you want your hand to be right on top of the heart. For larger animals, it would actually be a series of 2. So your hands, both your hands, one hand would be on top of the other, just like this. Your arms would be completely straight, and you would do chest compressions like this, making sure that you're allowing the lungs to expand again, that you're not putting your entire body pressure on the animal. Closing the animal's mouth, pulling the tongue out, breathing into the nose. 2 rather small breaths, especially for this kitten. We always have to remember that our patient's lungs are way smaller than ours, so make sure that you're feeling the lungs as you are breathing in, making sure that you're not expanding them too large. Doing the compressions again, 30 more. Taking 2 breaths. After 2 minutes, you would check your ABCs again. If you're not seeing, if your pet is still not breathing and you're still not feeling a heartbeat, then you continue doing cardiopulmonary resuscitation. I will be demonstrating how to use an ambu bag. So for this specific bag, it is far too large for this small kitten, but we need our smaller one. We do have a smaller size one downstairs, but it is necessary to stay in surgery because there is surgery going on. But I will be demonstrating for this purpose using a larger one today. So this specific ambu bag actually is attached to our oxygen source. So here's our oxygen line, and at this connector, it will be connected to our oxygen. We do have our flush valve here. Our flow meter here. So a flow meter will allow us to measure the amount of oxygen we want our patient to be getting. So during an emergency situation, if our patient has to be intubated, she will have an endotracheal tube in. The endotracheal tube will be attached right at this end. We will connect that endotracheal tube to our ambu bag, and that is in our patient. So once we have connected it, we will wait for this to fill up with oxygen. Just make sure that the oxygen is flowing. We will then squeeze the bag, give a good breath every 6 seconds. So this could be done while a professional is giving compressions. So the whole main purpose for our ambu bag is it is a main oxygen source. Okay, so now I'm going to start the process of scrubbing. So I've already washed my hands thoroughly with antiseptic. And then with using the pick, I'm actually just going to start with my fingernails. Just getting any dirt or debris outside of the fingernails that I see. Not too much. So now I'm actually just going to throw it right in the sink. Now we're going to take our Easy Scrub brush. So I'm going to start with my fingertips first on my left hand. Great. Now I'll proceed to my index finger. Which does have 4 sides, so make sure I scrub each side 10 times. Next finger and so on. Perfect. And then I'm going to move to my thumb. The outside of my thumb and then the inside of my thumb. now I'm going to start with my right. Start with my fingertips. Down here. Okay, so now I have my towel. I'm going to dry my hands. So I take it by the edge. So this hand is going to do the side, and then the other hand will be the other side. Okay, so now I am completely sterile, and I'm going to be showing how to unwrap the pack here for Dr. Lang. So our surgery today is a castration as well as a hernia repair. So we have our dry towel. So to unwrap the pack, I'm going to do it by the folds. Being sure to stay out of the sterile field. There we go. Drape. And now I'm just going to drape it directly over our patient. Perfect. So now the ends are considered non-sterile. Dr. Lang, go ahead. Now she will cut right in the middle where the incision will be. Okay, now I'm just going to blot some excess bleeding here at Dr. Lang. Very gently, nothing too crazy, just before she closes the incision. Everything look good? Yeah. Now I'll be doing the scalpel blade. So this is how I will place the blade on, just sliding it directly on. And then to hand Dr. Lang on the blade, do it with my fist this way. Great, thank you. This is great. Okay, so now I just want to talk about if anything ever does break sterility, what I would do. So if, God forbid, I did puncture a glove, I would have to remove it immediately. So I would step far away from the sterile fields and remove my glove. And then I will have the circulating nurse actually put more gloves on me so that I am sterile again. And then the same thing with the gown. Okay, so I'm currently monitoring for cat castration. Okay, so we just finished our castration on a feline. So now I'm just gonna unhook him, as well as bring him over into recovery. Unhook his ECG leads. And he's ready for recovery. Okay, so here we have our feline stay. So I'm just gonna go ahead and do the last surgical scrub before the procedure. Okay, so we just finished surgery. Now I'm gonna clean up the surgery suite. So first I just have our disposables here. No sharps. Garbage bin. Gonna make sure all of our monitoring supplies is put back properly and cleaned. So I'm gonna leave that aside to be cleaned. We'll take all of our instruments and put them to the side. And our dirty surgery pack. We do have a blade on our scalpel, which I will take off and put in the sharps. Perfect. Now I'll be putting all of our instruments in our bin to be washed. We do have some baby teeth we removed, so I'm going to make sure that we put those in a container. Our instruments will go in the sink to start the mechanical scrubbing process. Our drapes and our towels in the wash. And first, surgery suite. Now that we're all done, I have put away all of our instruments. I've also scrubbed all of that instrumental gear down on not only some with alcohol, some with hydrogen peroxide, but now I have accelerated hydrogen peroxide here. I will spray it down. As well as our counters. And let it sit for 10 minutes, and then I will be back to do it one more time, and that's how we clean the surgery suite. Okay, so to go over proper disposal of our hazardous waste containers, such as formalin. Formalin cannot just be dumped down the drain because it is considered a hazardous waste. So for this specific product, what you would have to do is actually neutralize it with a specific solution, and then after a certain amount of time, you are allowed to dump it down the drain. So these specific hazardous waste cannot go down the drain. They must be neutralized. Okay, I will be demonstrating how to clean surgical instruments. So I have all my instruments in a tray in our sink. I'll be filling it up with distilled water. As well as our Noble Sand solution. Great, so I will let this soak. So this is going to be our pre-soaking stage for about 5-10 minutes. And next I will be doing is our decontamination. So that is going to be manual scrubbing of each instrument. In our solution. So this is making sure that we get any remains of any tissues or substances off of our instruments. And then letting them dry to the side. And I'll continue to manually clean them. Okay, our next step to cleaning the surgical instruments is placing them in the ultrasonic cleaner. this will run for 3 to 6 minutes. Okay, so the next step in our sterilization is actually our instrument lubricant. So we'll be using this instrument lubricant. So I actually have this container filled with our instrument lubricant. So we'll take our instruments out of the ultrasonic cleaner and put it in our lubricant. Great. I'll let that sit for about 5 minutes. Okay, so I will be showing you how to wrap our spay pack that we just used. So to begin, I have our tray table here. So the first thing I'm going to do is actually put in our 2 forceps. Right here. I'm going to put in our spay hook. I'm going to put in our mayo and our medicine bombs. Make sure that they're closed and together up and to the side. Perfect. And now by size order, I will be putting all of our other instruments. So I will explain in just a minute. So I have 6 different kinds of hemostats, ranging from microhemostats to large hemostats. I'm sorry, mosquito hemostats to larger hemostats. I have our suture driver. And our tissue grasping forceps as well, which are the biggest. So I'm going in size order. As you can see, the smallest to the biggest. I'm going to place them in, and then actually using our scalpel holder, I'm just going to stick it in into instrument thumb holes and lay it down flat. Next, I'll be putting our gauze pads. So there's actually 20 in here, so I'm just going to separate them 10 and 10. Make sure that we always count the gauze pads. That's very, very important. And then our towel clamps. So I'll go ahead and clamp those on to our gauzes. Right on top. We have our drape and our indication stick. So for the indication stick, I'm going to put it lower to the pack, the lowest that could go, just to make sure that we have masked as aseptic as we can when we sterilize the pack. So now we'll wrap the pack. Okay, so putting our pack right in the middle, starting from my side first, holding it so it's nice and tight, and pushing it up against my body, and then doing an accordion measurement, just like that. Perfect. And I'll go ahead and do the right side, making sure that I try to keep it as tight as possible. And then our left side. It is very important to keep the pack nice and tight, just to ensure that the pack is sterile. Push it tighter. And then for the last wrap, I'm going to drape it around. A little too tight. There we go. And then fold under this tab right here. Great. Okay, the next step of wrapping our spay pack. So now I have a towel, which is going to be used for the surgical use to dry the hands. And I also have an indicator strip. I will put that on top of the pack and then wrap it one more time. So I use the tab first closest to me. Also make sure that we do a little accordion motion with the tab. We have multiple tabs here. I'll do the right side, the right tab. Make sure that we fold it in nicely so we can open it easily. I'll move on to our left side. And last but not least, the final tab. Pull it over like this, closest to my body, and tuck it in. Great. And then I have my tape here, my indicator strip tape. I'll put it right over here. March 5th. My initials because I wrapped the pack and read that this is a small spade pack. And that's how you wrap a spade pack. Okay, so I'll be wrapping a surgical gown. So the first step I'm going to do, I like to align my table with the edges. Perfect. So the first step I'm going to do is fold in our sleeves. So the gown should be facing towards you. For example, I like to use the table as if the gown, the table is the person and the person is wearing the gown. So to put this on right now, the sleeves are under like this. Now fold in our other sleeve. Perfect. And then I'll fold in our sides here. And then one more time. Just make sure my ties are out. I'll do the same thing with the other side. Fold in the back of the gown in. Okay, and one more time. I'm just gonna go back and do this one more time. It's kind of unraveled on me, so I'll go in one more. Okay, great. So make sure that our ties are out. And I'm going to accordion the top. So put it over once, flip it out, and then do accordion motion. Just like this. Down in here, as well as an indicator strip. I'll tuck it right under where it's visible. Make sure that you'll be able to see the indicator strip so that you know it's sterile. Okay, so I'm going to do the first tab closest to me. And then make sure I do a bunch of tabs on the inside so it's easier to open in the surgical suite. And it stays as sterile as possible when we open it. So it's always good to make the gowns as tight as possible because this will increase sterility. I'm sorry, I did the right tab, now we'll do the left tab. I'm pushing it up against the table and myself just to get it nice and tight. Like I said before, I'm adding multiple tabs, folding in. And then the last one, fold out. Now, really good to pull this one in and then tuck it right under. Good. There we go. I'm going to put our gown in here. I'm going to put one more, put our hand drying towel as well as another indicator strip right on top and do the same process. So the first tab closest to me. So the folds are make the pack easily accessible and easily make it very easy to open during, before surgery. Oh, good. indicator tape. Including a little tab for the end, so it's easily accessible. Put the tape on just like this, and I will write on my initials, the day I made it, which is today's March 5th, 2019, and then I will write that this is a surgical gown. And then that's how you wrap a surgical gown. Okay, now that I wrap my packs, I'm going to use our autoclaves to sterilize it. So the autoclave is considered a gravity air displacement sterilizer. So this specific sterilizer runs off of distilled water. So the distilled water will go inside right here. So I put the distilled water into the appropriate marking place. That distilled water would then turn to steam, heat up to about 350 to 370 degrees. So this sterilizer will take 15 minutes, and then it will, the steam will actually turn back into distilled water. Yeah, so it's pretty amazing. So I'm going to place my pack in here, as well as some other surgical instruments I have. So our autoclave is set to 270 degrees Fahrenheit. Sterilization time is going to be 4 minutes. Dry time is going to be 30 minutes. So now I'm going to go ahead and click start, and it will start preheating. And that is how we use our autoclave for sterilization. Okay, so our pressure range for our autoclave is 15 to 27 pounds per square inch. So to sterilize our autoclave, we do it once a month. It's a proper clean out. We actually have a special bleach cleaning disinfectant agent that we would run through the whole machine. We also have filters in the front and the back that we would clean out. After we do clean it, after the machine is cleaned thoroughly with the bleach, we will wash the bleach out. And yeah, that's it. We would do it once a month just to maintain our autoclave. Okay, I have our pack that I wrapped just this morning. So now with this pack, I do know that it is sterile. So as you see here, I have our indicator tape. So before, these black strips were not black, they were actually white. So this indication means that this pack was sterilized. Inside of our pack, we also do have indicator strips. So these strips will turn a different color when the pack is sterile. So when the surgeon will open the pack, they will not touch anything until they look at our strip and make sure that the pack is officially sterile and ready for surgery. Okay, so the first suture I'll be talking about is our 5-0 cutting one. So this suture is actually a curved cutting suture. So it's a curved cutting needle. So for this specific suture, it actually has 3 cutting edges. The third is actually considered on the inside. So it's on the inside and this way, right here. This needle is the most traumatic in our surgeries that we use. It's actually used specifically for thick skin or thick tissue. This needle produces the largest holes when you pass through the tissue. The next suture I'll be talking about is our reverse cutting. So as you see, the needle is called reverse cutting. This size specifically is a 4-0 and it is curved. So for our specific reverse cutting needle, it has 3 cutting edges and it's a very strong needle. It actually maintains the same sharp edges all along the body of the needle. So the main reason for this, it is very ideal for soft tissue closures. So this is an example of our taper point needle. So as you see here, so for a taper needle, it actually has a very sharp edge and a rounded body. So specifically, a taper point needle penetrates tissue without leaving a lot of damage behind because of the rounded edges that they have here. This specific taper point needle is good for suturing intestines or organs or even fibrous tissue. So for a straight needle, it is pointed at the way tip and then edges out along the edge and does get a little thicker. So our straight cutting needle is not used very often here at our practice, nor is it used very often in veterinary medicine, but I know it's very good for areas. Typically can be used for around the anus, and just to avoid the anal glands around that area, because you do not want to pierce the anal glands when you're doing a surgery around the anus. So next I'll be going over suture size. So actually for our 4-0, since we do here 3-0, 4-0, and 5-0, our 3-0 is actually technically larger than the 4-0, and 4-0 is technically larger than the 5-0. This is just larger in diameter. So I just wanted to go over our different shapes of our needles. So of course here we have our straight needle here. Like I discussed before, it's very good for using around the anus. And then we also have our curved needles. So curved needles can actually be full, half curved, or double curved. Just wanted to discuss our numbers here that we have. So we have half a C for our curved needle and 3/8 of a C. So when you see the 3/8 circle here, when you see the 3/8 circle here, it means that if a full circle were actually divided into 8 parts, that the continuous curve of 3 of the parts would be this shape. It just describes the different shapes of the needles here based off of a full circle. Okay, so the first suture material I would like to be talking about is our natural suture material. So that could be silk or even catgut material. So right here I have a 4-0 permahand silk suture material here. So this is typically used for short-term use. So these sutures will not be used for long-term, and they are very absorbable as well. Okay, so the next suture material I will be talking about is actually a non-absorbable monofilament material. So that would be our Ethylon right here. So for this sutures, the owners would have to come back to have the sutures removed for this specific material. And it is considered a synthetic material. Okay, so along with our nylon suture material, we also have our poly-Glaklin suture material. So this suture material as well as a non-absorbable synthetic monofilament suture material. Okay, so the last suture material I'll be talking about is another monofilament. This is called monocryl. So monocryl is absorbable, and it actually is for medium-term use. So this is definitely the most common suture that we use here. We use it in mostly all of our spay procedures. It is good for holding sutures underneath the skin for absorption later in life once that incision has healed. So next I will be talking about our suture pattern. So this is a very common suture pattern here, a very rough draft of what I drew. So this specific suture pattern is considered a simple continuous suture pattern. So as you see, the sutures are just continuous and they're flowing in and out of the skin, and then it is knotted up at this end. So this specific suture pattern is good for subcutaneous skin sutures, or the muscle layers on the linea alba. We see that a lot in our abdominal surgeries. Okay, the next rough draft pattern that we have here is our simple interrupted pattern. This is definitely the most common pattern that we see. It is also used for the same that the simple continuous sutures are used for, the same as the, could be used for subcutaneous space, muscles for the linea alba. But it's also regularly used for Penrose drains. So as you can see, the suture material go in, and then this would be the knot here. Suture, knot, suture, knot. So this is not a continuous suture. So the next rough draft suture pattern I have here is our horizontal mattress pattern. So the horizontal mattress pattern is actually ideal for places where there's a lot of tension. So as you see here, the suture materials are here. The suture lines are here, and then the knot is tied off here. This would be our incision here. And the last suture pattern I'll be talking about is a little modification of the mattress pattern. So this specific one is actually called our cruciate pattern. So as you see, it actually results in X sutures here, and the knot is where my little circle is on each end here. So this is very good for wound closure. Okay, next I will be talking about the difference between eyed needles and swag needles. So for eyed needles specifically, there's 2 different kinds. So first there's single eyed needles, and then second there's French style needles. So single eyed needles actually need the suture to pass through the end of the needle. So because of this, it actually causes a lot of damage when the needle is being pulled through the skin and or through the tissue. So this definitely can be very traumatic on the skin. The second is the French needle. So this is the second version of the eye needles. So the French needle actually can be just as damaging and traumatic. So the difference between the French and the single eye needle is that the French needle actually has two eyes to thread our suture material through, which just makes it more damaging to pass through the skin. So what a swag needle is actually very beneficial to veterinary medicine. A swag needle actually comes manufactured with suture material already on the needle, which is very atraumatic and causes a lot less damage than our eye needles. So we do have absorbable and non-absorbable suture materials. So the first one that is non-absorbable, so those suture materials will not be broken down by natural processes in our body. So those materials can actually stay in the body for over 2 years. So for our non-absorbable sutures, those have to be removed. For our absorbable sutures, those actually can start disintegrating within 7 days. The body starts breaking them down, and typically they are fully gone within 60 days. Okay, so we do have two different types of suture materials. So that would be monofilament or multifilament. So multifilament suture is actually two different strands of suture material combined together into one, and the monofilament is actually just one single strand of suture material into one suture. So typically we do use monofilament a little bit more and more often than multifilament, because multifilament can be a little more traumatic on the skin just because of the braided texture. Okay, so today we'll be removing Zaza's staples. As you can see right here, she has two. She had a little mass removed. So with my staple remover, it's okay, you don't have to start close. I'm going to try my best to just do one at a time. Okay, Mama. There's one. I know you're a little anxious. That's it. You're done. Good job. And that was it. Okay, so I just saw Zaza. So for his staple removal, his skin looked absolutely beautiful where the staples were underneath. There was no discharge, no redness, no swelling, and it looks like the area where the incision was healed beautifully. So it was not open. It was no longer an open wound. So we got the okay. I had one of our doctors, Dr. Bassman, check the incision, and she said that it was okay that we go ahead and remove those staples. If there was any redness, swelling, discharge, that would be a sign of infection. And we would have to either remove those staples and flush out the wound, or keep the staples in for a little longer, or even add additional staples. But we did not see that today, so we went ahead and we removed those.